evening, everyone. A very warm welcome to the next module of our genitourinary cancers. This is an integrated cancer education in the field of genitourinary cancers. Friends, we know that over the past 10 to 15 years, both prostate cancer and urothelial cancers have significantly advanced in our understanding of the disease burden, the application of the basic sciences, and the evolution of the treatments in both the subjects. The incorporation of the multidisciplinary strategies has actually led to better outcome and better patient care. Concurrently, the researchers are actively conducting clinical trials for our better management of these patients in the field of targeted therapies, immunotherapies, and novel combinations of treatments in the various forms of these malignancies. As a result, the landscape of urothelial cancers has witnessed a remarkable progress, offering new hopes and improved outcomes. This is a unique program where we have 4 modules. We did the basics and the understanding of the choice of treatments for prostate cancer in the last module, and we would be exploring the treatment options in advanced prostate cancer and looking at the emerging horizons. You look at the program, we have one senior faculty who presents the data on the different aspects of the disease itself. And then we involve some of the young budding oncologists to present their cases, and the panel discussion being moderated by yet another senior faculty along with some of the panelists from around the country. We have a really pan-India participation. And overall, this education program aims to cultivate a strong foundation of knowledge in the field of GU cancers, enabling students to grasp and understand the subject and also effectively contribute and be participants in these presentations. With those words, I extend a very warm welcome once again. And we have none other than Vineet delivering the talk on exploring treatment choices in advanced prostate cancer and emerging horizons. We have 2 young oncologists, budding oncologists, Mahesh and Nishant, who would be presenting cases, and none other than Akhil, who would be moderating the panel discussion. I thank AstraZeneca, Dr. Saloni and Dr. Ritika for the support they have extended to this series of the programs. I thank my colleagues in the Indian Oncology Foundation and add my ideas for piloting all this so beautifully. We already have more than 200 registrations on the program, and then hopefully this would grow. Back to you, Priyanshi. Thanks once again, and my gratitude to everyone who's found time to log in and be a part of the proceedings this evening. Thank you so much once again.
Thank you so much, sir, for giving our audience the overview of the program once again. So today we'll be covering the module 2 of this program and looking at, like sir mentioned, the treatment choices which can be used for advanced prostate cancer patients, and what are some of the upcoming therapies that are being tested in clinical trials at present and which would become probably the line of therapy in the future years to come. So I welcome Dr. Vineet Talwar, who's the Director of Department of Medical Oncology at RGCIRC New Delhi. I welcome you, sir, and we look forward to a great session starting now. So over to you. I'll share my screen and then you can start.
Thank you very much, Saloni, and thanks to Dr. Ved for giving me this opportunity to talk on an issue which is a burning issue nowadays, when patients transit from hormone-sensitive prostate cancer to the hormone refractory, that is the CRPC, castrate-resistant prostate cancer. So how do you go about treating these patients, and how do you look into the nuances of the patient treatments? Because now you have a lot of drugs in the armamentarium, and not only the drugs, you have different modalities of treatment, whether you talk of chemotherapy, whether you talk of hormone therapy, whether you talk of theranostics, or whether you talk of the latest, which is the PARPI inhibitors, and how to use them in combination and isolation. So that is what I would be discussing with you today. So can I have my slides, please?
Yes, sir. Just 1 minute. There's some. Yeah. So let me know when you can see.
Yeah, thank you, Saloni. I can see it. Can you please go to the next slide?
Yes. Yes, sir.
So this would be an overview of the prostate cancer, whether you look at the treatment options or you look at it as a management overview. And I would be basically discussing two stages of prostate cancer. One is the mCRPC, that is the non-metastatic castrate-resistant prostate cancer. And of course, the other one is the metastatic CRPC or castrate-resistant prostate cancer. So for the castrate-resistant prostate cancer, I would be using CRPC. And for the non-metastatic, I would be calling it as mCRPC in short. And what are the emerging therapies and what are the ongoing trials? We'll just go through it. Next slide, please. So this is the natural history of any patient who goes through the treatment paradigms in prostate cancer. And initially, it is a localized prostate cancer. Patient is diagnosed. The intent of treatment is curative. And slowly, the patient might go into the castrate-sensitive metastatic setting or may present as a de novo castrate-sensitive prostate cancer. And from there, after a period of time, the patient might progress to a metastatic castrate-resistant prostate cancer. So initially, you have a patient who has a localized disease, you have local treatments, you have active surveillance, you have a combination of androgen deprivation therapy, or you have anti-androgen therapy or a combination. And then slowly you find that the patient slips from the curative therapy to palliative therapy. Next slide, please. And as I was mentioning, the prostate cancer is comprised of multiple disease states. You have the localized state where these patients are newly diagnosed. They just have a rising PSA. Along with that, they might have a biochemical failure after local therapy. And once they have that, when you have a rising PSA, which is non-castrate, and there is a biochemical failure after the conventional hormonal therapy, this small subgroup is known as non-metastatic CRPC, which will be our focus today. That is the mCRPC. And then subsequently, the patient progresses from there to the hormone-sensitive metastatic prostate cancer. So you have localized, you have non-metastatic CRPC, and then you have the hormone-sensitive metastatic prostate cancer, and of course, the later one is the metastatic CRPC. So I would be briefly focusing on the mCRPC and then subsequently going on to the CRPC. So if you see the Globocan, you find that the estimated number of new cases of prostate cancer, when you traverse from 2020 to 2040, they are going to rise from 1.4 million to about 2.24 million. And so along with it, the number of deaths from prostate cancer are unfortunately going to rise from 375,000 to about 725,000, which is just the double. So in 20 years, not only the incidence, the death also from prostate cancer is going to double. This is an unfortunate phenomena which is predicted. Next slide, please. No doubt, metastatic CRPC is lethal disease with the best overall survival of 3 years. We talk of 3 years, but that is unfortunately only in the clinical trial. But when you go to the real world practice, it is generally about 1 to 1.5 years, or at the best, nearing 2 years. So from a metastatic CSPC, where you look at generally around 3 to 5 years, you have a shrinkage of the overall survival to about 1 to 1.5 years in real world practice, although in clinical trials you see that it approaches around 3 years. And this has been aptly been shown by the TAX 327 trial, which employed docetaxel, or you could use abiraterone or enzalutamide. Next slide, please. The treatment options in metastatic CRPC are primarily based on the evidence of phase 3 randomized controlled trials. So in this, it has been broadly divided into pre-docetaxel setting and post-docetaxel setting. Now, why is that so? Because the first trial to show benefit in CRPC metastatic was the TAX 327 trial, in which docetaxel was used. And then subsequently, we were spoiled for choices, and we had a lot of drugs like abiraterone, enzalutamide, and lately apalutamide also, which is there. Then, if the patient progresses on that, or the patient has a HRR mutation, then of course we have a combination of PARP inhibitors, which is olaparib and rucaparib, which is seen in the PROfound and the Triton trials. And then subsequently, lately, we have a host of trials in which a combination of the AR and the PARPI are used, which I would subsequently delve into. But the unfortunate part here, which you can see on the right side, the median overall survival, unfortunately, is not much as it would have been in the hormone-sensitive setting. So whatever we are able to try in this setting, we are not able to approach the hormone-sensitive scenario, which is about 3 to 5 years. And here we are just looking at 1 year, 2 years at the max. Next slide, please. So when you do the treatment decision making in these patients, there are multiple factors which influence us. Of course, it is the disease factors, that is the volume of disease, low volume versus high volume. If you have a low volume disease, you would push more towards the AR. If you have a high volume disease, you would give chemotherapy if it has not been given in the HSPC setting. Again, high volume, high distribution of metastasis, symptomatic if the patient comes in a crisis, a visceral crisis, then of course you are more tempted to give chemotherapy as compared to the AR. Other disease characteristics, the tumor histology, the rate of change of disease burden, the prior treatments, because if the patient has got prior AR, then you give taxanes. If the patient has got taxanes earlier, you give the other way, vice versa. And of course, you look for the patient fitness, the comorbidities, because some drugs have special side effects. So when you have 2 or 3 protocols, you check upon the patient comorbidities and decide accordingly. Next slide, please. So mCRPC, again, as you see by this schema, you have a condition when the patient is diagnosed, the patient is treated with curative intention and has only rising PSA. There is a local relapse, there is watchful waiting. Patient is given ADT and other treatments. There is rising PSA only. There are no distant METs. So that patient is clubbed under mCRPC. So you have no radiological evidence of disease. And along with that, you have a rising PSA. And you have a PSA doubling time of less than 10 months. So these three would qualify into a category which is known as mCRPC. Next slide, please. And this has been aptly shown in the NCCN guidelines, in which where you have PSA doubling time of less than 10 months, it comes into mCRPC, and there you can give 3 ARs, that is apalutamide or darolutamide or enzalutamide. These are CAT1, that is category 1 recommendations in these patients. And these also have been seen in the AUA, the American Urology Association. And serial PSA measurements at 3 to 6 month intervals are done. You calculate the PSA doubling time at the development of castrate resistance. You assess for development of metastatic disease using the conventional imaging or PSMA PET at intervals of 6 to 12 months. Meaning thereby, as I had reiterated, the patient should have a rising PSA level, at least more than 2. These patients should have a PSA doubling time of less than 10 months, and they should have no radiological evidence to suggest that there is disease elsewhere, which would qualify it as M0 or non-metastatic CRPC. Next slide, please. And these are the summaries of the studies which are in the M0 CRPC scenario. If you use apalutamide plus androgen deprivation therapy, the Spartan trial was there, which showed that in these patients, their metastasis-free survival was 40 months versus 16.2 months with a hazard ratio of 0.28. The Prosper trial, again, instead of apalutamide, was enzalutamide plus ADT versus ADT alone. And again, here, as I said, that there were rising PSA despite castrate levels of testosterone. Baseline PSA was more than equal to 2. PSA doubling time was less than 10 months. And here again, the median metastasis-free survival is about 36 months, as against 40 months in Spartan. Here, of course, the hazard ratio again is 0.29. The third trial, which is using darolutamide, this was darolutamide versus placebo. And here again, you see the median MFS is about 40 months versus 18.4 months, again with a hazard ratio of 0.41. Side effects were consistent with those reported in the prior clinical trials in men with CRPC. There was not much difference if you go through the safety profile of Spartan, Prosper, and Aramis. Next slide, please. So only 1 in 2 patients will receive 1 line of active therapy in mCRPC. That again impacts their overall survival, and early optimization of the treatment is the key to further qualitative improvement in the survival in these patients. Next slide, please. So now we go from M0 CRPC to the conventional CRPC, which is M1 CRPC. So in M1 CRPC, you have the lesion there, you have the rising levels of PSA with castrate levels of serum testosterone. So in this, we have to look at the treatment of disease, the alleviation of symptoms. If the patient has any skeletal related events, they have to be checked. And along with that, you have to give either bisphosphonates, which is zoledronic acid, and with that, you can give denosumab. If the patient has too much pain at one local site, which may be a weight-bearing area, then palliative RT can be given to those areas with pain. Otherwise, these patients are treated on the lines of metastatic castrate-resistant prostate cancer. Next slide, please. So these are the therapeutic strategies according to the NCCN guidelines, where you can see that if the patient has not received prior docetaxel, then in these patients, you can give novel hormonal therapies or the ARs, which can be abiraterone or enzalutamide. Or if the patient has a BRCA mutation, in these patients, you can give olaparib and abiraterone combination, which I'll come to later. If the patient has only bone metastasis and is in CRPC, radium-223 is a choice which can be given. Another study was with talazoparib, that along with enzalutamide in HRR mutated patients, these patients can be offered that if they have not been given any AR prior, that is, if the patient has not been given enzalutamide in the hormone sensitive category. Again, it can be interchanged. If the patient has received docetaxel prior, the patient will not be given docetaxel. Then in these patients, it can be given cabazitaxel. And whether cabazitaxel is better or abiraterone and enzalutamide is better, that I'm going to discuss subsequently. Another thing which should be kept in mind is that when you have a patient in a CRPC category, you have lot of disease which is shown on the PSMA PET, and you have a minimal rise in the PSA. One should always be aware that can this patient have a transformation? So if you find that on PSMA PET there is not much avidity of the disease load which is there, then probably with a low PSA and a non-avid PSMA PET, one should go for a conventional FDG PET and see whether the avidity is there. If the avidity is there, then these patients should be subjected to a biopsy, because these patients might have a small cell or a neuroendocrine transformation in patients who are having HSPC earlier. So for them, the first line of management will not be these hormones. They would be chemotherapy, and chemotherapy, the level 1 recommendation is for cisplatin and etoposide, or you can give docetaxel and carboplatin, or you can give cabazitaxel and carboplatin in very, very small subset of patients. But given a choice, these patients should be offered cisplatin and etoposide as first line. And then you will find that there is a remarkable improvement in the general condition and performance status of the patient, which would have been adversely affected if you wouldn't have done a biopsy and given these patients ARs or ADTs. Next slide, please. So these are the changes in M0CRPC and mCSPC, which have changed to CRPC. So you find that whenever you have a patient who's progressing from mCSPC, that is castrate-sensitive prostate cancer, to a castrate-resistant prostate cancer, these patients should always be looked upon to see for the genomic profiling, and of course, whether these patients can be given ARs either in combination or chemotherapy, that is cabazitaxel or docetaxel. They can be interchanged. If the patient has received docetaxel in the CSPC arena, then these patients can be given cabazitaxel. And if the patient has not been given docetaxel there, then of course docetaxel, and subsequently if the patient progresses, we can give cabazitaxel. Abiraterone can be given, and enzalutamide also can be given, preferably abiraterone first, and after that enzalutamide if the general condition of the patient is not that great. The interchangeability is having some negative signals according to the trial, so it's better to give Abi followed by Enza. Or if the patient has not got docetaxel, can give that. If the patient is in visceral crisis, you prefer chemotherapy over the ARs. And all through you have to give these patients ADT cover if bilateral orchiectomy has not been done. Next slide, please. So cabazitaxel, is it better than the ARs? And what is the condition of the vision trial in when lutetium was used as theranostics? How do we go about selecting these patients as far as the genomic selection is concerned? We'll just go for these. Next slide, please. So this was the trial which answered the question whether cabazitaxel is more effective or the abiraterone or enzalutamide in the CRPC strata. We find that when you give these patients to the double-armed trial in which cabazitaxel was given in one arm and the other arm was AR inhibitor, which was abiraterone or enzalutamide, we find that the median PFS was 8 months versus about 4 months in AR, and so was the overall survival. There was a difference of about 4 months. So definitely this trial proved that if the patient is fit and if you have to get a greater benefit, then it is better to give cabazitaxel than to give AR inhibitors in this setting. Next slide, please. Where does theranostics come into being? You see lutetium, the function of lutetium is that it binds with a high affinity to the PSMA on cell membranes. And it is a radioactive atom that emits beta particles, resulting in the prostate cancer cell death. So this phenomena, which is used for diagnosis, it is used in the therapeutic scenario in which this is linked to the PSMA 617, and this is taken into the cell by endocytosis and then goes inside and causes nuclear damage or DNA damage, and thus leads to apoptosis of the cancer cells. Next slide, please. So this was the VISION trial, which showed that definitely there was a significant improvement in the radiological progression-free survival, which was about 8.7 months versus 3.4 months, which was the standard of care. And again, median overall survival, there was a difference of about 4 months. So if the patient has had AR or docetaxel and still the patient is having avidity as far as the PSMA PET scan is concerned, then these patients should be thought of theranostics, and this is the trial which says that it has a definite benefit. Next slide, please. Now switching gears from theranostics, from AR, from taxanes, it has been found that in prostate we have a lot of actionable mutations, and amongst them the commonest is the BRCA1 and BRCA2, out of which BRCA2 is the commonest, followed by ATM and followed by the CHEK, and then you have a host of other germline pathogenic mutations which can be explored and can be employed as far as the treatment is concerned. Next slide, please. So based on that, when you use the PARP inhibitors, there are certain PARP inhibitors which have been currently approved either in isolation or in combination. So in isolation, you have olaparib, which was approved in May 2020. And this was the progression following treatment with enzalutamide or abiraterone. So if you have a patient which harbors the HRR gene mutations, then these are the patients which can be subjected to treatment with PARP inhibitors like olaparib. And similarly, it was for rucaparib. And these were the patients which were previously treated with AR or taxane-based chemotherapy. Recently, there have been trials in which it has been thought that the co-targeting of the AR and the PARPI may lead to a synergistic benefit and may lead to an increased improvement in the survival of these patients. So with that in mind, the first trial was the PROPEL trial, in which olaparib was combined with abiraterone. And this was given in those patients who had these deleterious mutations, BRCA mutations. And this was approved in May 2023 by the FDA. And subsequently, another trial was there in which niraparib plus abiraterone was used. This was the magnitude trial, in which this was again proven that the usage or co-targeting of the AR plus PARPI would be beneficial. The third trial, which is the recent trial, it is talazoparib plus enzalutamide. This has been approved. A cohort 2 has been approved, which are HRR gene mutated metastatic castrate-resistant prostate cancer patients. So either you can use PARPI in isolation or you can use in combination. Next slide, please. And this inhibition of PARP, it mediates the synthetic lethality in prostate cancer patients. And here you can find that there is a blockage of the PARP, and the blockage then again leads to the inactivation of the HR-associated genes, which are the BRCA1, BRCA2, ATR, ATM, CHEK. And when they are pharmacologically inhibited by the PARP inhibition, it can lead to the lethality if a cell is lacking the HR repair capacity. So this synthetic lethality is employed whenever the PARP inhibitors are given to these patients. Next slide, please. So as I was saying, there is a co-targeting between the PARP and the AR. You have a synergistic effect because the PARP inhibition leads to increase in the activity of the novel hormonal inhibitors via the androgen receptor dependent transcription, which I had just shown you in the cartoon. And again, the novel hormonal inhibitors, they induce the HRR deficiency. So when they induce the HRR deficiency, definitely the PARP inhibition is more. So on one side, you are increasing the activity of NHA by PARP, and on the other side, the NHA itself induce the HRR deficiency. So that leads to a synergistic combined effect, which leads to anti-tumor activity in HRR mutated patients and in some non-HRR mutated patients also in prostate cancer, which was seen in the PROPEL trial. Next slide, please. So this is basically a summary of all the trials which I was talking about, which are in combination. So the first which came in line was the PROPEL trial, in which olaparib was combined with abiraterone. Second was magnitude trial, niraparib with abiraterone. Third was the TELAPRO trial, in which talazoparib was combined with enzalutamide. And fourthly is the CASPAR trial, in which rucaparib has been combined with enzalutamide. So in this, these two, basically you find that the stratification of cases was prior taxane in case of PROPEL and the site of metastasis. In magnitude, it was the BRCA1 and 2 HRR mutated cohort. They did not take the non-mutated HRR patients. In TELAPRO, again, the TELAPRO second arm, the cohort 2, which has been seen in these patients, they all took the HRR mutated patients. And so is the CASPAR trial. So PROPEL was the one in which it was unselected patients, which were HRR mutated and non-mutated. So you had a cohort of HRR mutated patients, and the other one was the ITT, which was intent to treat patients. And next slide, please. So when you come to PROPEL, you see the radiological progression-free survival. You find that irrespective of the age, the site of the distant mets, whether the patient has received docetaxel prior or not, and the HRR mutated status or the non-mutated status, you find that all the subgroups, the abiraterone and olaparib arm is better. Next slide, please. And so is the overall survival in these groups, where you find that both the HRR mutated and the non-mutated, it is working there. Of course, in patients who are HRR mutated, it works better, simply because you have the oncodriver and you have the PARPI which is blocking it. But because of the co-targeting in both these subgroups, you find that this drug is working. Next slide, please. So in patients who have bone-only mets, what can you do? Is there any need to change? Well, if you have radium-223 in your armamentarium, this is the study, that is the AL-SIMCA trial. So here again, you find that in bone only, mind you, bone only mets where you don't have any visceral mets. So that was the inclusion criteria in these patients. You find that there is a OS benefit in these patients. Next slide, please. So how do you select treatment in CRPC based on the biomarkers? If the patients have BRCA1, BRCA2, HRR alterations, you give PARP inhibitors. Either you give it alone or you give it in combination. If the patient has microsatellite instability high or tumor mutational burden is more than 10, then in these patients you can give immuno-oncology drugs like pembrolizumab. And then again, if the P10 deletion is there, there is a new drug which is capivasertib that can be given in these patients. Next slide, please. So this is the sequencing and the possible algorithms as I had discussed with you, starting from the first line mCRPC based on the prior therapies. If you have given taxanes prior, you give AR. If you have given AR prior, you give taxanes. Then side by side, at the inception of CRPC, you check for the HRR mutations. If the mutations are there, then you can give either PARPI alone. If the patient has not been exposed to abiraterone, then you can give abiraterone and olaparib, or the patient can be given enzalutamide and talazoparib. And in both HRR mutated and non-mutated, according to the PROPEL trial, you can give abiraterone and olaparib. If the patient has HRR mutation, then you can give enzalutamide plus talazoparib according to the PROPEL trial, or niraparib according to the magnitude trial. Once the patient progresses on this, then you can look for the avidity on the PSMA PET scan. If it is there, then you can subject these patients to lutetium, or you can give cabazitaxel if the general condition and performance status of these patients is good. So this you can sequence in second line or third line. If you have patients which are fortunate enough, which have only bone-only mets, these patients can be given radium-223 on a selective basis. Along with that, one has to be very careful about these skeletal related events, because these patients have been exposed to AR in the hormone sensitive setting. So you do a DEXA scan, you check for the vitamin D levels, and along with that, if these patients have skeletal mets, you can give denosumab or zoledronic acid, depending upon the situation. Next slide, please. So these are the new things which are coming up. BiTEs, the bispecific antibodies, CAR T cell therapies, they are also having a foray in prostate cancer. Immune checkpoints, I told you the patient has a microsatellite instability or patient has a TMB, tumor mutational burden, which is high, then of course we can give this. Cytokines and vaccines are coming in a very big way in this arena. Next slide, please. So this was just to show that how the BiTEs and the CAR T cell therapy work. They work both by activating the T cells to kill prostate cancer cells, although the mechanism of action of both is totally different, but the end result is blockage of the cancer cell and activates the T cells there to kill the cancer cells. Next slide, please. These are the other trials which are in progress, and probably in times to come, they will be answering a lot of questions. So you are combining theranostics with other drugs, and of course, you find that these are phase 3 trials also. There are 2 are phase 3 trials, and other trials in which darolutamide with ADT is there. That again is a phase 2 trial which is in the offing. Next slide, please. The other trials are biomarker selected trials. So apart from the ARs, you have a combination of IO plus AR or IO plus PARPI. So the field is wide open, and we are trying to look at all kind of combinations and permutations to get the best bet at the lowest possible side effects, which would translate into a good quality of life in these patients. Next slide, please. Again, these are the trials in progress for advanced prostate cancer. Next slide, please. So I would summarize that metastatic, non-metastatic CRPC, the addition of AR prolongs the metastasis-free survival, the OS, and translates into the quality of life, because the more you can prolong the non-metastatic CRPC setting, the better it is for the patient. And these are the ways by which you can prolong it and get the best benefit. And sequencing in CRPC metastatic is complicated. There are a lot of drugs. How you have to choose which drug to get the maximum benefit, you take the help of next generation sequencing. And with that, you can see whether the patient can be given PARP inhibitors, or the patient can be given immuno-oncology drugs, or the patient can be given additional targeted drugs. So future maybe combinations, lot of combinations and permutations I've shown you, which are there in the pipeline. And the ones which have come in the clinical practice is the combination of AR plus PARPI inhibitors. Now you are combining immuno-oncology drugs with PARPI, immuno-oncology with AR. So as I told, the field is wide open. But at the bottom line is that patient selection has to be very careful, and it should be conducive to the patient's comorbidities. It should be conducive to the patient's preference. Some patients might like intravenous, some patients might like only oral drugs. It should be conform to the patient's general condition, should conform to the patient's performance status at this point of time. And of course, we should look at the other supportive care measures, that is the skeletal related events, and have to take due cognizance of that whenever we treat, and we have to supplant them with the active treatment which is there. So I think with this, I'll stop. I thank you for your patient hearing.
Thank you so much, sir, for that wonderful session and taking us through the whole management of advanced prostate cancer, and then also telling us, what are the new emerging therapies that are coming up. So thank you for that discussion, the session, and I believe that, the students would have definitely benefited from that. Thank you for your time, sir. And we will now move on to the next part of our module, which is the case-based discussions. And we have two young medical oncology, DM medical oncology students with us who will be presenting two cases. One will be a non-metastatic castration-resistant prostate cancer, and the other would be a metastatic castration-resistant prostate cancer, like we've discussed in the modules. And the session will be moderated by Dr. Akhil Kapoor. Thank you, sir, for coming and moderating this session for us. And he's the assistant professor in the Department of Medical Oncology, Tata Memorial Hospital, Varanasi. And the expert panel that we have with us is Dr. Francis James, who's the professor and head of Department of Radiation Oncology, Regional Cancer Center, Trivandrum. Dr. Suresh Patil, who's the senior consultant at Department of Medical Oncology at Capital Hospital, Jalandhar. We have Dr. E. Prasad, who's the senior consultant in Department of Medical Oncology, Apollo Proton Cancer Center, Chennai, and Dr. Arun Chandrasekhar, who's a consultant at Department of Medical Oncology at Aster MIMS in Calicut. So I welcome the whole expert panel today, and I welcome the case presenters who will be first presenting us the case and then subsequent discussions. So we will start with first case presenter, the Dr. Mahesh Chaudhary, who is a DM medical oncology student at TMH Hospital, Varanasi. And then, Akhil sir can take over from there. So let me share my screen for the case.
So Dr. Mahesh, you can start the presentation.
Okay.
We'll be discussing each case separately. So just after completion of presentation of Dr. Mahesh, we'll have a discussion. It will be followed by next presentation.
Okay, sir. Good evening, everyone. We start with first case of non-metastatic CRPC. Okay. Next slide, please. Okay. There is a 80-year-old male with a good performance status. PS is 1 with Gleason score is 5+4 on 9, and the patient presented with the clinical symptoms or sign lower urinary tract symptom. Has multiple comorbidities like hypertension, diabetic, and past history of a CAD with post-stenting and reduced ejection fraction 45%. He is a retired businessman and physically morbid but active person. Next slide. History of treatment is first started with external beam radiotherapy, 50 grade, 25 fraction in May 2007, and in view of rising PSA 2.2 or PSMA PET suggestive of there is a local disease recurrence on left lobe of prostate. SBRT to prostate to a dose of 35 gray per 5 fraction prostate and 25 gray per 5 fraction to wall pelvis received on 2017. Post RT 4 years 6 month on follow up and patient on goserelin till 2022. PSA value rising from 19th April 22, 1.243, and then 17 August 2022 is 1.65, and then 25 October 22 is 2.61. For their PSA doubling time is around 6.9 month, and for their darolutamide therapy initiated in December 22. Next slide, please. Patient on multiple patient has multiple comorbidities, and patient on multiple medications like antihypertensive and anti-diabetic medication with also aspirin. Next slide. Okay. A diagnosis of non-metastatic CRPC, for that imaging of 60 gadolinium 68 PSMA PET CT done on 25th November 22, that shows PSMA evidence that enhancing soft tissue lesion was noted in the right peripheral zone of the prostate gland in apical and mid glandular region, and that measuring 1.6 into 1.4 centimeter in size, and max SUV is 16.43. And that online PSA doubling time calculator was used, and PSA doubling time was 6.7 month, taking that the last three values. Next slide. And this is the PSA doubling time calculator used for count PSA doubling time, and that shows 6.9 month, and for that start darolutamide. Next slide. Okay, this PSMA PET scan or that showed only prostate or prostate gland uptake, and that is only even uptake on and physiological uptake in a parotid gland and renal. Next slide. Okay, this is also PSMA PET scan only showed that is a only prostate uptake, no any lymph node uptake showed. For that is a only prostate recurrence in a local, not any metastatic. Next slide. Okay, this is a PSA levels from February 2022 to April 2022. There is a PSA rising from August 2022, 1.65 and then 2.61. And for the darolutamide started on December 22. And then after that decreasing PSA from December 22 to 2.39, and last April 2023 is a 1.07. Next slide. So treatment with apart from lower urinary tract symptom, the patient has no other symptom, and patient ongoing treatment from last 8 months. No adverse effect related to darolutamide despite on having multiple drugs and comorbidities and the age of the patient. Negligible fluid retentions with darolutamide makes it feasible to be used even in patient with the reduced LV function. And reason for darolutamide start is the patient has a compromised ejection fraction and multiple comorbidities. Okay, next slide. Okay, thank you. And okay, next questions.
Yeah. So thank you, Dr. Mahesh, for the presentation. Are our panelists available?
Yes.
Yes, I can see Dr. Francis, sir, Dr. Arun, and Dr. Prasad as well, and Dr. Suresh as well. No. Yeah. So, can I have the slides towards the case? Yeah. Yeah. So, Arun sir, first I would like to get your comments. This is a case of diagnosed as non-metastatic CRPC, and the patient has reduced ejection fraction. So first, I would like to take your opinion. Do you see routinely non-metastatic CRPC cases, and how is the frequency? Yeah.
Actually, with the advent of PSMA PET, honestly speaking, I've not seen any patient with non-metastatic, CRPC. Always the PET picks up something. Now, as you said, if the PET shows some loco-regional node or local prostate uptake, I think that is the patient who you would include here. So most of those last time I've seen those kind of patients is, I can't remember, I think probably in TMH types. But, I think prior, because of conventional imaging, we used to pick them much more common, but with PSMA, it's less there. In this patient, I believe he received radiation the second time after 10 years for a small residual disease, and then he went into prostate. So I think that's a good option where you kind of delay the giving a systemic therapy in an old patient with multiple comorbidities. And with the choice of drug, yeah, I think I totally agree. Darolutamide is the safest drug among all the three drugs available, less drug interaction, and obviously lesser amounts of fatigue and neurocognitive dysfunction. So somebody's 80 years, obviously that would be the best drug. So I think I agree with most of the points raised. Yeah.
Francis, sir, I would like to get your comments with your immense experience and a lot of patients. Sir, what has been the observation of nmCRPC in your setting, sir?
10 years ago, we used to have many non-metastatic CRPC. Then the standard investigation was CT scan plus bone scan. Recently, as mentioned by earlier, with the introduction of PSMA PET scan, the numbers have gone down considerably. I have few patients who have been non-metastatic CRPC with disease in the prostate and lymph nodes, not outside pelvis. Those patients were treated with enzalutamide, and they are doing well. Enzalutamide is tolerated well by most of the people, except occasional patients who have extreme tiredness or patients who have history of seizure or something like that, which is very rare, which occasionally happens, I agree. But I mean, darolutamide is a wonderful option, provided the cost implication is not a factor. So these days, it will be very difficult to find non-metastatic CRPC. But if you find that, it is reasonable to offer one of these molecules, either one of these. Among the three, as you can imagine, enzalutamide is the cheapest, and darolutamide is the most expensive. Darolutamide, as it doesn't cross blood-brain barrier, CNS side effects are very low and tolerated well. I have only one patient on darolutamide, so I find it to be tolerated very well, but not many patients in a government hospital can afford to have darolutamide, as you would imagine. And when we describe a patient to be non-metastatic CRPC, I think we have to say the repeated testosterone level, because that would be one of the mandatory criteria to call CRPC. I think I haven't seen that reading. I have seen the PSA reading, but not testosterone.
Yeah. So this patient is a part of darolutamide phase 4 study. So the strict vigilance as per the protocol has been done. The patient was castrate resistant. So castration levels were confirmed with the testosterone level. It was actually less than 20 in this patient. Sir has beautifully summarized most of the important points related to the nmCRPC, the past and present, and also the available options and the points to check. Recently, sir, as sir highlighted, there was a patient who was on triptorelin, but when the patient had rising PSA levels, we thought it is, and the scans were showing only local disease, no distant mets. So we were thinking that it might come as nmCRPC, but when we screened for the trial, the testosterone level came to be 80. So then the patient was not considered as castrate resistant, and sir has already highlighted the point of checking testosterone levels. So that is very, very important before stamping any patient as nmCRPC, else it is not actually castrate resistant till the time you document the levels. So Dr. Suresh, I would like to get your comments in such situations where the patient has undergone surgery, then PSA levels are rising, the patient is on ADT. Does your radiation oncologist is convinced to give radiation in patients who are castrate resistant, but only local disease is present, but patient is already castrate resistant?
Good evening, sir. Till now, I have not seen even a single case of non-metastatic CRPC. But at our center, we do have a detailed tumor board discussion regarding for such cases. But most of the time, I prefer giving systemic therapy for such patients with apalutamide, which is, as sir has already told, which is a costlier option. So we are left with enzalutamide for the patient.
Okay, okay, got your point. Thank you. Dr. Prasad, I would like to get your comments on this same question. Patient underwent surgery, then was on ADT. While on ADT, within 2 years of surgery, the patient developed rising PSA values, and PSA doubling time was close to 6 months. Whether this patient should undergo radiation as a part of salvage option, or the patient should receive nmCRPC treatment with systemic drugs which is available. So this is a dilemma. What is your comment and suggestions?
Both the options are right. So since disease is only localized and it is going to be in only one place, probably in a non-irradiated site maybe, then the addition of a local treatment would definitely be of use. Though we may or may not have a proven randomized clinical trial, but any non-metastatic with a localized disease, radiation would still be part of the treatment. So we do have darolutamide and all the newer drugs approved for this specific subgroup. Definitely, when we are looking at the outcomes, addition of radiation would definitely be useful.
Okay, I will request to get comments from Francis sir on the same point.
In the olden days, I had given, before the introduction of all these fancy molecules, I used to irradiate such patients if it is localized to prostate. And they are a set of patients in whom there will be some response, but it is short-lived usually. I can only say a few patients because I have done that for only a few patients. But recently in a meeting, I have heard that the Tata Memorial Center in Kolkata has a fairly good series, and the duration of response lasts for a few years. That's all verbal communication. There is no published data. So as a standard, you cannot say that this will produce durable remission. So there is no strong level of evidence to support this.
Okay. Okay. So we had discussed such scenarios because such scenarios arise significantly in the practice when the patient has undergone surgery. If the patient had previously undergone radiation, then this problem doesn't arise. But most often when the patient has undergone surgery and the patient is on ADT, still on ADT, and develops a PSA rise, and there is nothing in scan, then this problem arises. We have discussed similar cases with our radiation onco team. We do MDT regularly. The comments which I got from our radiation team that if the patient is castration resistant, the benefit of even if the disease is non-metastatic, the benefit of radiation is significantly limited, because in the trials also, when prior hormonal therapy was not utilized and the patient underwent radiation, the results were not good. So I think when in this situation the patient is already castrate resistant, then the benefit of radiation will be limited. But yes, nobody can say that it will be zero, but yes, it will be slightly limited. So that is one of the reason to choose one of the 3 drugs which are available in nmCRPC setting.
Another thing is probably darolutamide did not include a PSMA PET CT scan. It was more of the conventional CT scans which was part of the trial. But now that at least in India we do have the PSMA PET scans and it's all available at a cheaper cost compared to that of the Western country. So probably a direct comparison might not be practically relevant, but definitely choices are there.
So completely, this point is very valid. Actually, PSMA PET CT has completely changed the way we practice, and this is one of the differences from all the trials. All the trials have utilized CT scan plus bone scan, all the prostate cancer trials, while we are utilizing PSMA PET, which is definitely known to bring out small distant mets, though it might be oligomets, but still, definitely. So regarding the choice between the 3 drugs, I will request to get a final comment from Dr. Vineet Talwar sir. He is a very avid and expert and senior uromedical oncologist. I would like to get sir's comment.
Thank you, Akhil. As I had mentioned earlier, when you see across these trials, all these trials have got very good hazard ratios. They are hovering around 0.26 to 0.3. So if you just look at the trials and you try to treat the patients, then it would be difficult. So now, based on the comorbidities, I think I would be choosing the drugs, whether the patient has any CNS mets, or the patient has any hypercholesterolemia, the patient has any transaminitis, the patient has diabetes. Accordingly, I would sift out, see the comorbidities, and align the drugs accordingly, and then choose the protocol, whichever it may be. That would be my take whenever I find that the trials are almost similar as far as the final outcome is there.
Completely agree, sir. Thank you for bringing out the very most important aspects. In our experience as well, the comorbidities and drug-to-drug interactions, such patients where there are multiple comorbidities, there is a lot of interactions involved. So that is why we try to select the drug with least interactions. So whenever it is not possible to chase the other ongoing drugs. For example, in this patient, the patient has cardiac comorbidities. The patient is on multiple medications for the same, and other drugs were found to have significant interactions. So darolutamide was selected. And also the good point is that darolutamide doesn't have fluid retention. That is why it is safer than enzalutamide and apalutamide, both of which have significant some amount of fluid retention at least. Enzalutamide has some amount of crossing of blood-brain barrier. That is why it is caused seizures, while this is not the case with darolutamide, which has least penetration. So yes, we can utilize the drug accordingly as per the fitness of the patient and other comorbidities. Completely agree. So any comment related to nmCRPC? Else we can go to the second case.
So we do have a few live questions coming in from the audience. So should we take it up right now, or should we discuss it after the second case?
If there is a case question related to this case, then we can take it now.
So not directly related to this case. It will we start having questions. Okay, sure, we'll take it afterwards.
Yeah. So I think now we can move to the second case. Yeah. Second case will be presented by Dr. Nishant. Dr. Nishant is DM Medical Oncology student at AIIMS Rishikesh. He has come to Varanasi for some externship training and others.
Yes, Dr. Nishant, you can begin.
Good evening, sir. Thank you for the opportunity. Today I'm presenting the case of a metastatic CRPC. Can we have the case? Yeah, this is a case of a 58 years old man. He's a government employee and is hypertensive on amlodipine 5 milligram and telmisartan 40 milligram for last 1 year. And he presented with chief complaints in September 2023 with difficulty in micturition for last 3 to 4 months and urinary urgency and hesitancy for 2 months and burning micturition for 1 month. He was evaluated and he did not have any hematuria, fever, dysuria, or retention of urine. Next slide, please. On examination, he was ECOG PS1 without any pallor, icterus, clubbing, edema, or lymphadenopathy. He was of average build and the vitals were within normal limits and all the systemic examinations were within normal limits. The external genitalia was examined, the penis scrotum and the bilateral testes were normal, and on DRE there was grade 3 prostatomegaly. Both the lobes of prostate was enlarged and nodularity was present. It was firm on palpation and there was no tenderness. The next slide, please. So it was a prostatic enlargement, which was symptomatic. He underwent an ultrasound on 3rd of October 2022. It suggested a grade 2 fatty liver with a normal kidney with a distended urinary bladder and a prostate of 39 grams with normal echoes. The pre-void volume was 250 cc and post-void was 26 cc. The PSA was done at that time, which was raised of 126.32 nanograms per ml. It was a baseline PSA. So, it was diagnosed to be a case of prostatic carcinoma. The patient underwent PSMA PET in September 2022, and it suggested avid PSMA. It suggested avid uptake at the prostatic bed, and there was an avid bilateral external iliac node mass of SU max of about 12.35, and the size of about 3 into 2 centimeter. The PSMA avidity was seen at the mesorectal deposit with SU max of 4.72. The PSMA avid subtle sclerotic lesions were also seen in the femur sacrum, where it was maximum of 18.06, and a D8 vertebra, right scapula, right clavicle, and right femur. So it suggested a bony mets of more than 4 sites, and also involvement of the extra axial skeleton. Biopsy was done, and a 12-core biopsy suggested a prostatic acinar adenocarcinoma with the Gleason score of 4+5, grade group 5. It was diagnosed with a high-grade, high-volume metastatic prostatic adenocarcinoma, non-visceral mets with only bony mets. Next slide, please. So the patient with this diagnosis was given the option for the orchiectomy, the medical or the surgical. The patient opted for the surgical orchiectomy, and patient underwent the surgical orchiectomy. And he was started in view of the high volume disease. Patient was started on injection docetaxel with abiraterone, and the patient also underwent HRR and BRCA testing, which was found to be negative. The patient received 3 cycles till March 2023. The tolerance was fine. There was no grade 3, grade 4 toxicities, and no dose modification was required. Next slide, please. The scan was done in March 2023. It was not what we actually expecting from the case. The scan showed that the uptake at the prostatic bed was minimized, but there was increased uptake. There was a new uptake at paratracheal and bilateral external iliac nodes with SU max of 2.88 and a PSMA avid sclerotic subtle nodule at bilateral scapula with bilateral ribs and C3, C7, D8, L2 vertebra, bilateral sacrum, bilateral iliac bones, bilateral acetabuli, bilateral ischium. And overall, the disease was suggestive of a progression in view of the increased bony mets. The PSA was done. The PSA at that time was 1.28 nanogram per ml. So it suggested that the disease increased in the metastatic sites with maintained level of PSA on treatment. So it was a case of on treatment progression. Next slide, please. So it was a debatable thing that what next to be done. So the first thing was done that the histopathology was reviewed if to see for any other variant histology was there or not, and it was reviewed, but it failed to show any sarcomatoid or NEC variant. So it was labeled with the diagnosis of metastatic CRPC on progression on post-docetaxel and abiraterone. So it was planned to start with the cabazitaxel in second line in view of the metastatic CRPC. It was planned for the doublet that cabazitaxel and carboplatin in view of aggressive variant histology and a very rapid progression, that is very rapid on treatment progression. The patient received 3 cycles till July 2023 and completed 6 cycles till September 2023. And the imaging are as followed. Next slide, please. Yes, so we can see that the patient is maintaining a stable disease and a partial remission, that partial response. There were no new lesion, stable primary disease and metastatic sites, no visceral lesions, and maintaining PR, and a PSA is maintaining with the latest PSA of 0.43 nanogram per ml. The patient is tolerating the therapy well. There is no evidence of any grade 3, grade 4 toxicity, and patient is doing fine. Next slide, please. So this case actually gave us this idea that the concept of aggressive variant histology of prostate cancer. Can I show the second slide, the next slide, please? So this was a paper from the ESCO that showed 7 different criteria, which any of these criteria, if the patient fulfills, then can be labeled as aggressive variant castration resistant prostate cancer. It either the histological evidence of non-classical histology or a histology of a small cell prostatic carcinoma, pure or mixed. Either there could be exclusively visceral mets only, or there could be radiographically predominant lytic bone mets by plain radiograph or CT scan, bulky disease of lymph nodes of more than 5 centimeters, or high-grade Gleason's more than 8 tumor mass with prostate or pelvis, low PSA, that is less than 10 nanogram per ml at the initial presentation, or there could be presence of neuroendocrine markers histology, that is positive staining for chromogranin A or synaptophysin, or plus any of these other soft markers like elevated LDH level, malignant hypercalcemia, or elevated CA levels, and or there could be short interval like less than 6 months of androgen independent progression following the initiation of the hormonal therapy with or without the presence of the neuroendocrine markers. So by reviewing this case, the patient did not show, the histology failed to show any non-acinar adenocarcinoma histology. But looking into 7 criteria, that patient progressed lesser than 6 months on treatment. that the classical first line treatment we started the therapy with, the patient progressed within 6 months and without showing any other, and also maintaining the PSA level. So labeling the patient to be one of the among these criteria as to be an aggressive variant castration resistant prostate cancer, we gave the patient Xin and the cabazitaxel and the carboplatinum as the agent, and the patient is doing quite well. So thank you for the case. This was the whole summary of the case. Thank you for the patients listening. The case is open for discussion.
Thank you, Dr. Nishant. So this is a somewhat interesting and not so common scenario actually, but yes, it happens in our practice on and off. This patient was started having high volume disease, started on triplet treatment with ADT, docetaxel plus abiraterone, which is now one of the standard of care options for the first line treatment in fit patients. The patient had a serological response, but had symptomatic worsening with new onset of pain actually after 3 cycles of docetaxel plus abiraterone. That is why we got a repeat scan done. In the routine practice, we don't routinely do a scan after 3 cycles or 4 cycles of dosi plus abiraterone. It was actually due to symptomatic worsening. We did a scan, though there was serological response. And since there was only close to 2.5 months of starting of treatment, and there was no small cell component, we didn't expect small cell transversion in so small time. So I would like to get comments from anyone and everyone who is with us. Francis, sir, you wanted to make a comment?
Yeah, I would be happier if I can get the histology. Since there are lymph nodes, we can biopsy to see whether it is lymph node small cell differentiation. If it is histologically proven, I'm very happy to take this pathway of cabazitaxel plus carboplatin, which is quite likely to work well, or alternatively cisplatin plus etoposide, either one. But why I was saying that if the patient does not have small neuroendocrine differentiation, I was thinking whether it is a good idea to give this pathway or lutetium PSMA therapy, which will be better for this patient. That's what I was thinking. I would think lutetium PSMA will work well if there is no neuroendocrine differentiation. And in such a patient, we are looking for very short time of we might, if the patient doesn't have neuroendocrine, then the patient is quite likely to have a bad outcome. And then which one is better? That's what I was thinking, cabazitaxel or lutetium. What do you think?
Yeah, sir, I think in such cases, the PSMA uptake of the lesions and the symptoms of the patient will guide us. This patient was having increased amount of symptoms, and PSMA therapy takes some time to act, at least 4 to 6 weeks to start action. While if Cabazi plus Carbo starts to act, it usually works within 7 to 10 days. That was one of the reasons of selecting this treatment. And also, PSMA uptake was to the tune of, though it is not an absolute criteria, it was to the tune of values were to the tune of 10 or 11. While our nuclear medicine team who are doing routinely PSMA therapies, they say that roughly, though it is not absolute, the rough values where PSMA therapy gives the maximum of benefit is to the tune of 25 and above. This is just a number, not an absolute criteria to select, but yes, gives us some idea where the therapy might be much more effective, and it is just a rough guide. Dr. Arun, sir, you would like to make a comment on this case? Any comment on the therapy selection and any other thing which you would like to do in such a patient? This patient underwent HRR testing, which we do routinely, and even in HSPC cases now.
Okay. Yeah, I think metastatic prostate cancer now, it's come as a routine, sending an NGS if possible. This is a difficult case. Thankfully, not faced this kind of situation, but I think it's probably some kind of aggressive histology would be the thing, PSA being almost normal. So again, with the lutetium therapy, I would have expected PSA to, have increased along with, this, along with the progression. So the chemotherapy, I think, is a very good option. I've not used this combination. I've mostly used single agent carboplatin. So I think Cabazi 20 and AUC 4 is what some of the easily tolerable doses are. You use that or AUC 5 in this patient?
AUC4.
AUC4.
As per the protocol, yes.
Okay, and currently after the end of treatment, was the patient put on anything else or just?
This patient has completed 6 cycles of Kawasi carbo. Then the patient is carboplatin has been stopped and patient is on further 3 cycles of cabazitaxel. Like we do usually give if the patient is responding well, we continue up to 9 to 10 cycles of cabazitaxel in the same way.
And after Kawasi, if the patient is still in response, would you?
Yeah. This patient is still in
something?
response. The patient has completed 9 cycles around 15 days back, and this patient came in OPD yesterday only, and the patient is kept on observation.
Okay. Any role of maintenance, something like Enza, would you, means he's been exposed to abiraterone, would you give enzalutamide because this patient is not going to do too well, or would you reserve it for progression?
Yeah, I think next best bet would be PSMA therapy, and I would start it in no time. We had done a separate NGS as well to see for PTEN mutations. PTEN deficiency predisposes the patient to a very aggressive tumors. So we have now started to do 3 IHC tests at the baseline of the patients. That is PTEN IHC, RB-IHC, and P53 IHC. The main paper of Kawasi plus carboplatin that clearly showed molecularly defined aggressive variant prostate cancer have the maximum benefit of addition of carboplatin. On that basis, we have started to utilize these 3 ICs in the routine practice. PTEN deficiency, we do routinely test in all our patients of HSPC itself because we have an ongoing trial of capivasertib where patient is PTEN deficient. The patients are selected to started on capivasertib plus abiraterone. Around this incidence is in India to the tune of 20 to 25%, and these patients do poorly on single agent hormone therapy, that is for sure. Other thing is that there is another gene, SPOP gene mutation. With our HRR panel, we include SPOP gene. The usual HRR panel does not include SPOP gene, and SPOP gene is a marker of good response to hormonal therapy. So all these modifications, molecular derived modifications, and adoption of these practices has become the standard of care at our center now. So it is, I think the world is evolving and there are many new things coming up, though there are no strict guidelines for the same. But yes, I think we are moving towards the same rapidly.
Yeah, I think you can make the guidelines now. No, we are got enough population to do that. Look to ourselves. But it's excellent work. Yeah, that's very good to know. Okay.
Thank you.
This is a good case. I've learned something from this as well.
Thank you, sir. Vineet, sir, you would like to comment or add anything?
Well, this case would be a nightmare for anybody. You started a triple therapy hoping that you'll get a survival in excess of 4 years, and here you'll end up not even 4 months.
Correct.
So I think I really don't know how this patient would do, but as of now, as you have given cabazitaxel, some kind of maintenance I feel should be continued, or if you give a chance, then the patient would come back very rapidly. I agree with the treatment which has been given. It's unfortunate that patient has not responded. The other thing is, I don't know how wise it would be to repeat a biopsy and see what is the situation now, and again take a recall. But otherwise, I think next step should be theranostics, as you already said.
Yes. Thank you, sir. Thank you for the valuable comments. Any other comments from anyone? Dr. Prasad, you would like to make any comment on this case? This, as sir highlighted, Vineet sir highlighted, this is not a usual case, but yes, we see such cases. Why we are seeing more of these cases? We are doing a randomized trial between triplet therapy with full dose of abiraterone versus triplet therapy with reduced dose of abiraterone. So we are doing a randomized trial of abiraterone full dose versus 250 mg dose with meal in CRPC setting. At the same time, we are doing a randomized trial of abiraterone plus docetaxel, abiraterone 1000 mg empty stomach versus docetaxel plus abiraterone 250 milligram with meal. So that is why we are getting more and more patients strictly followed up and presenting to us. So as a part of the standard follow-up, these patients are on a strict follow-up and they report to us early as well. So that is why I think we are getting more of such cases, and it has become important to find. And these patients, this study is known as Dahlia study. It is on undergoing recruitment at our center presently. So it seems that yes, the 4 years triplet therapy, the median PFS and OS, which were suggested by the PEACE 1 and other studies, I think our patients have somewhat different biology, and I do not seem to find close to 4 years PFS in majority of the patients. It might be 1 or 2 patients doing good, but in majority of the patients, they are progressing within 1.5 to 2 years. That seems to be the median PFS, even with triplet therapy in our settings. That is what we are seeing. But yes, we cannot say on the basis of 100 patients. We have a long way to go. It is a 300 patient trial. Dr. Prasad, any comments?
I would still go with the same treatment line, because these are all these unusual high-grade, high-volume diseases which would definitely need to be started with chemo as a first line and probably reserve the hormonal treatment as the subsequent line treatment. There's a very high chances of this patient recurring sooner. But again, it's good to see PSA in decimals compared to that what it was a 3-digit in the beginning, and probably somebody who progressed on dosing but subsequently responded well to cabazitaxel. Probably judicial use of carboplatin had really made the change in the PSMA scan before and after the use of the second line treatment. But as the other colleague had suggested, I would still consider using any of the hormonal treatment as kind of a maintenance instead of having a drug holiday. Probably some hormonal manipulation to keep the disease under control might be one of the options.
I agree that this patient is very aggressive and we should not wait. I completely take the point. And also just utilizing this stage, I would like to make a comment on the metronomic protocol, which we use very routinely in practice. Sometimes patients are not eligible for PSMA therapy due to either logistic issues, cost issues, or either the PSMA uptake is not so strong. So the nuclear medicine team thinks the chances of responses are not so great. We utilize a lot of metronomic treatment with cyclophosphamide and dexamethasone 0.5 milligram BD and cyclophosphamide 50 to 100 milligram 2 weeks on, 1 week off. We have a series of close to 120 patients now in CRPC settings. And the overall response rates are to the tune of 60%, and the duration of responses are close to 8 to 10 months. That is much better than many of the other therapies which are approved in this line. So this is also another treatment which is not very commonly utilized, and it is not anywhere in the guidelines, but we tend to utilize it, and we have found good results. And the publication for this data is also under process. So wish to share the same. Vineet sir, do you utilize metronomic treatment anytime in prostate?
Yeah, we are giving. In fact, like you are giving Dexa with cyclophosphamide, we give pulse dose dexamethasone, which has been mentioned in literature in those patients who have been heavily pretreated, and they get some PFS benefit, although not so great, but there is a mention of pulsed dexamethasone. So those patients who are not really fit and who have exhausted the current regimens, we give them to buy some time. Sometimes it is logistical or financial issues. Then, these patients have some qualitative time.
Thank you. Thank you, sir. If there are any other comments, or else we can go to the other part.
So we have a few questions that we got from the audience. So shall I just read it out and we can, you can discuss with the panel?
Sure.
So one of the questions that has come is there any role of hormone in recurrent prostate cancer? Is the question.
So recurrent prostate cancer, what is the exact meaning?
They've not mentioned it here.
Yeah,
So.
it is not clear in the question, but yes, hormonal ADT is the backbone of any treatment. Any treatment requires ADT backbone, either surgical or medical castration is the backbone. And use of novel hormonal agents are has become very important and much is now much utilized in the practice. So yes, it is definitely there.
Right. And sir, we have got a case, like a case scenario from one of the audience. So I'll just read it out. A 78 years old man, initially hormone naive, metastatic castration sensitive prostate cancer, was on gozirelin initially controlled, but then PSA kept increasing. Then planned for enzalutamide alone, but the patient cannot tolerate the drug. So how to deal with this case?
So my comment on that would be, we have utilized enzalutamide or abiraterone like drugs in patients who are more than 100 years also. It is not about the age. Age is actually a number, but it has different connotations. What is the problem with tolerance? Is the patient having multiple fluid retentions? Is the patient having fatigue? If that is there, sometimes I reduce from 160 mg to 120 mg, or if only the only problem is fluid retention, adding some amount of diuretics is sufficient most of the time. So we need to go into the detail why the patient is not able to tolerate, what is the actual problem, if the patient is having any other significant comorbidity, if there is any drug interaction. All these things need to be cross-checked. Anybody would like to add anything? Vineet sir or anyone?
No, I agree with you. At the outset, the information which has been given to us as far as the question is concerned is not adequate. But then, yes, if the side effects are there, then we can tailor the treatment accordingly. Or sometimes, you switch over to the other drugs. As I had mentioned earlier, you have to tailor according to the comorbids and the tolerance. So there can be interplay between them. Definitely.
Thank you, sir.
So we have just last two questions. One is, I think we have a few participants who have not joined from India. So they're asking, is there any alternative to PSMA PET scan as it's not available in their country?
So yes, as I discussed in the presentation as well, CT scan plus bone scan is an accepted alternative to PSMA PET. And in all the trials, most of the trials, CT scan plus bone scan has been utilized. So it is not a problem. CT scan plus bone scan is most of the time sufficient. If only the patient is having significant symptoms but not getting picked up on CT scan and bone scan, then you need to add other modality. For example, sometimes what happens, we utilize MRI of that specific area to get a idea whether actually there is any marrow metastasis or not. So it can be done on the basis of other radiological investigations which are all easily available. It is not mandatory to have PSMA PET, but yes, PSMA PET is now the favored approach because it's a one-stop solution and gives a good and in detail idea, has very high sensitivity as well.
In our center, we have a trial ongoing where they're comparing PSMA PET to whole body MRI, T2 and diffusion sequences. And apparently the radiologists say that your MRI might be able to pick up a little more, perhaps. So they're doing a study based on that. So even whole body MRI, but you need a 3 Tesla machine. Otherwise, your scan will take almost 1 hour. But if you have a 3 Tesla, that's also an option.
Okay. Very well highlighted. Thank you.
And I think, sir, we have just one last question. What is your opinion about low dose abiraterone along with docetaxel?
So as I highlighted, we have multiple studies ongoing, both in CRPC setting and HSPC setting. In CRPC setting, in the NCCN, you will find there's a clear-cut footer where it is saying that 250 milligram abiraterone with low-fat meal can be utilized, where 1000 milligram cannot be utilized due to various constraints, either cost or sometimes patient does not want to increase the pill burden. Some patients tell that I will take only one tablet I cannot take 2 or 4 tablets. So that is also one of the reasons of utilizing lower doses. And we have an ongoing randomized phase 3 trial with 3 participating centers. Hopefully, we'll be able to answer it in randomized fashion.
Thank you, sir. I think that is it for the live questions that we received from the participants. Yeah.
I can see Ashok Vaid, sir.
Yes, sir.
Yeah. Thank you, sir.
So the panel discussion today was very enlightening, and we did get a lot of insights, and I hope the students did benefit from the discussions and the points that were made by our expert panel. I thank everyone for joining in for the panel discussion today, and thank you, Dr. Akhil Kapoor, for moderating it well. And I request the audience to kindly fill the feedback form and tell us if you would like us to change something about the program. And last comments from A.K. Vaid, sir, to close the session.
I think that was a great session, great presentations, and what a marvelous panel discussion, and bringing out the points of day-to-day practice. And I can't thank enough to everyone who participated, took out time, and people have joined from India and abroad as well. And we would like to continue with this amazing activity where it's truly a participative medicine. Senior faculty presenting, moderating, and the oncologists in the making are presenting their cases and then getting into a discussion mode. Truly, truly very participative. I thank Mice Ideas, AstraZeneca, Dr. Saloni, and Dr. Ritika, as I said in the beginning as well, and to all the faculty. And see you soon with module 3 on the urinary bladder cancer. Till then, goodbye, take care, and thank you once again.
Thank you.
Thank you, sir.
Thank you.